So today's topic is inflammatory bowel disease. So can anyone tell me what is IBD? Can anyone tell me what is IBD? What is inflammatory bowel disease? Basically, it is a inflammatory autoimmune condition which basically involves the GI tract. It can involve some portions of the GI tract or it can involve whole of the GI tract. Okay. So IBD represents a group of intestinal disorders that cause prolonged inflammation of the digestive tract. It is a spectrum of chronic idiopathic inflammatory conditions. As you can see, this is a picture of colon and this is an inflamed colon. This is an inflamed colon and this is a normal colon. Okay. Most commonly involved part is ileum or ileocecal region of the intestine. Now, it has been classified into two, that is ulcerative colitis and Crohn's disease. Ulcerative colitis is a disease that causes the mucosal inflammation and ulcers in the lining of the large intestine, that is colon, mainly colon and rectum. While Crohn's disease is a chronic relapsing and remitting inflammatory disease of the GI tract affecting any site from mouth to anus. So you can, as you can see, from upper GI to lower GI tract, any part can be affected. Most common part affected in Crohn's disease is ileocolic region, while in ulcerative colitis it is mainly the colon which is involved, and there are multiple complications such as malignancy, bleeding, perforation and formation of strictures. Now as you can see in the picture, this is a healthy colon, while in Crohn's disease you can see that there is a wrapping of fat around the colon and there are formation of fissures, there is cobblestone appearing, okay, and there is muscular hypertrophy, which are the characteristic features of the Crohn's disease. While in ulcerative colitis, as you can see, the colon is thinned out and there is ulceration within the mucosa. So fissures, cobblestone appearance, muscle hypertrophy, fat wrapping are seen in Crohn's disease, while in ulcerative colitis there are only ulcers in the mucosa. This is a healthy colon. This is the ulcerative colitis colon that is having multiple ulcers, and this is the Crohn's disease having a cobblestone appearance and polypoid. Cobblestone appearance and polypoid mucosas. Epidemiology. In United States, it is currently, and this is the data of the United States, IBD is not very common in Asian countries. It is basically a disease of Caucasians or Europeans. Okay. Which race it is associated with? Basically, IBD is associated with which race? A specific race has been linked to IBD. Which is that race? And that is why the United States is having such a large prevalence of IBD. Which race? Ashkenazi Jews. Basically, they were the Jews of the North European descent. And they have some genes which play a role in the development of the IBD. Okay, it is currently estimated in US that about 1 to 1.3 million people suffer from the IBD. Ulcerative colitis is slightly more common in males, while Crohn's disease frequently affects the women. Diet, OCPs, perinatal and childhood infections, atypical mycobacterial infections have been suggested but not proven to play a role in development of IBD. So basically it is an autoimmune condition, genetic condition, which has been linked to the Ashkenazi Jews, and it is a disease of Caucasians. It has been said that the multiple factors can be associated with it, but it has not been proven. Okay, so prevalence per 100,000 person, Crohn's disease is 26 to 199 cases, while in ulcerative colitis it is 37 to 246 cases. If you see the adult data, this is the data combining the adults and children. Okay, so if you see the adult data, it is 201 per 1000 adults and 238 in UC. Now etiology. Etiology, multiple, as we know that the multiple factors have been linked to the development of the IBD. Infectious agents such as viruses, measles, mycobacteria, genetic factors, ethnicity plays an important role. Then environmental factor, diet, smoking, psychological factors, stress, emotional or physical trauma. Okay, pathophysiology. Now, what happens in IBD? As we can see in the picture, there are dietary and bacterial antigens that penetrate the intestinal wall, and they encounter and activate the immune system to produce inflammation. Antigens enter the wall of the intestine and they activate the immune system, and a dysregulated inflammatory response occurs. Okay, leading to inflammation. There are multiple factors involved. Then we have epithelial, as you can see in the picture, there are epithelial defects through which the antigens enter and they activate dendritic cells, macrophages. Dendritic cells again activate CD4 T cells, which lead to the production of interleukin 12 and activation of Th17, Th2 and Th1 cells, which again lead to production of multiple inflammatory factors such as TNF alpha, interleukin 13, and ultimately all these lead to the inflammation of the mucosa of the intestines or the GI tract. So this is in nutshell about the pathophysiology of the IBD. Basically, antigen enters, activate the immune system. In immune system, what is activated? Dendritic cells, macrophages, CD4 T cells, which results in the production of multiple inflammatory factors such as interleukin 12, 13, interferon gamma, TNF alpha, and ultimately leads to mucosal inflammation. Now, variety of epithelial defects have been described in Crohn's disease and ulcerative colitis. Defects in epithelial cells will lead to the influx of bacterial components such as dendritic cells and macrophages, which activates the CD4 cells. This activated CD4 cells activate other inflammatory cells like B cells, variable T cells, and recruit more inflammatory cells by stimulation of homing receptors on the leukocytes and the vascular epithelium. Inflammation in IBD is maintained by influx of leukocytes from the vascular system into the active disease site. This influx is promoted by the expression of adhesion molecules such as integrins on the surface of endothelial cells in the microvascular area of inflammation. You don't need to remember all these specific details at your level. You need to only remember what happens in nutshell. Okay, if you remember that, then you will be able to write a little bit about the pathophysiology of the IBD. Again the same thing, macrophages, dendritic cells, T cells, adipocytes, fibroblasts to produce TNF alpha. The target cells are endothelial cells, again macrophages, Paneth cells, myofibroblasts, effector cells, which again cause angiogenesis in endothelial cells. What will happen with them? They will cause angiogenesis. Macrophages will release interleukin 1, 6 and TNF and cause production of pro-inflammatory cytokines and suppression of regulatory macrophages. Then there are multiple factors basically involved. Now, clinical manifestations. Okay. Clinical manifestations. Clinical symptoms are same in both the case, that is diarrhea, abdominal pain, cramping, bloating due to bowel obstruction, hematochezia or blood stool, low grade fever, decreased appetite, weight loss and anorexia, fatigue and arthritis. These are the basic common IBD symptoms. There are multiple features present in signs and symptoms present in IBD, but these are the common ones. Okay, diarrhea, abdominal pain, which is cramping or bloating type due to bowel obstruction, hematochezia due to blood in stools, then low grade fever, decreased appetite, weight loss, anorexia, fatigue, and arthritis. How do you differentiate between IBS and IBD? How do we differentiate between IBS, irritable bowel syndrome, and inflammatory bowel disease? Blood loss. Blood loss is commonly seen in IBDs, but it is not a feature of irritable bowel syndrome. Okay, then fever can be seen in IBD, but it is not a feature of irritable bowel syndrome. Then anything else? Weight loss. Weight loss again it is a feature of IBD, will not be seen in irritable bowel syndrome. Now, there are certain features which occur only during the active phase of IBD, but there are certain features which are unrelated to the inflammatory activity of the IBD. Okay, so in the active phase, not in these features such as conjunctivitis, iritis, episcleritis, mouth ulcers, fatty liver, liver abscess, portal pymia, mesenteric and portal vein thrombosis, venous thrombosis. These are basically seen in the active phase, not in the remission phase of the IBD. Okay, while there are certain features which are unrelated to the activity. Okay, so these features are autoimmune hepatitis, primary sclerosing cholangitis, ultimately leading to malignancies such as cholangiocarcinoma, gallstones, amyloidosis, oxalate calculi, sacroiliitis, ankylosing spondylitis, Crohn's with HLA-B27 positivity, and then metabolic bone disease. These are not related to the activity. Okay, so there are certain features which are related to the activity of the disease, while there are certain general features which are not related to the activity of the disease. So what you basically need to remember which are present in the activity of the disease, that is conjunctivitis, iritis, episcleritis, mouth ulcers, then fatty liver, portal pymia, liver abscesses, then mesenteric and portal vein thrombosis and venous thrombosis. Okay, these are basically present in the active phase of the disease, not in the remission. It is a very long topic and I have tried to compile it so that it becomes short. It is a very long topic and it is very difficult to remember every feature of IBD. The diagnosis established by physical examination, endoscopic biopsies, then radiological tests and the blood tests. Now, physical examination, the main features are oral apoptosis, abdominal tenderness, masses, anal sacs, fissure, fistulae, and nutritional deficiencies. An important feature in children is growth retardation. Okay. Now, how does colonoscopy and endoscopy helps us in the diagnosis? Colonoscopy helps to determine the pattern and severity of the colonic and terminal ileum inflammation and allows the biopsies to be obtained. Basically, colonoscopy helps us to visualize up to the ileocolic junction so that we can determine the site of the disease, and accordingly we can differentiate whether it is Crohn's or it is ulcerative colitis. Okay, then we have endoscopic features such as aphthous ulcers, then deeper ulcerations, post-inflammatory polyps which indicate previous inflammations, but always accompanied by intervening normal mucosa, which is an important differential feature between the Crohn's disease and ulcerative colitis. Now, rectal and colonic biopsies should be examined to find the nature of inflammation, that is ulcerative versus Crohn's. Collagenous colitis, microscopic inflammation, if macroscopic appearance is normal, and inflammation. So, biopsies will help us to determine whether it is UC or CD, and whether it is a collagenous colitis or there is a presence of a infection. As you can see, this is our normal colon. Endoscope is going in. This is our normal colon. Here they are taking a biopsy from the colon. This is a mass, that is colorectal malignancy, and here you can see colitis, features of inflammation. Okay. Now, radiological, these are obsolete now with the presence of endoscopy and colonoscopy. Nobody goes for these investigations, but earlier they used to be done. That is barium enema and barium's small bowel follow through X-rays. In barium enema, barium is inserted into the rectum. Then fluoroscopy was used to take the image of the bowel, and rarely used. Now rarely used due to colonoscopy, and was useful for identifying the colonic strictures and fistulas. Okay, so barium enema was used for identifying the colonic strictures and fistulas, while barium small bowel follow through X-rays. Patient was made to drink the barium sulfate suspension, and then fluoroscopic images were taken. And over the time, they were useful for looking inflammation and narrowing of the small bowel. Now, blood test. What blood test you should do in inflammatory bowel disease? First will be to diagnose the presence of anemia. Okay, now this anemia can be present due to iron deficiencies or B12 deficiencies. It can be microcytic or macrocytic. Then there could be presence of hypoalbuminemia, which suggests severe disease. The best markers of inflammation severity is elevation of CRP. And then we have anti-Saccharomyces cerevisiae antibodies ASCA, which are positive in 50 to 60% cases of Crohn's disease, and ANCA, which are positive in 50 to 60% cases of UC patients. So in blood tests, basically the tests are for anemia, hypoalbuminemia, then CRP levels to detect the inflammatory activity. Then you have ASCA antibodies, which are positive in Crohn's disease. Then you have ANCA antibodies, which are positive in ulcerative colitis. Now, how do you differentiate between the two? First and foremost thing, that Crohn's disease can involve any part of the GI tract. Okay, most commonly ileocolic region, while ulcerative colitis mainly involves the colon and the rectum. It spares the anus. Now, terminal ileum involvement commonly seen in Crohn's disease. Ulcerative colitis, it is seldom seen, while colon involvement in ulcerative colitis is very common. Then rectum involvement is seen in ulcerative colitis more. Involvement around the anus is more common in Crohn's disease. Okay, so anus is involved in Crohn's disease more commonly, while rectum is more commonly involved in UC. Okay. Then bile duct involvement, higher rate in UC. Then distribution of disease, patchy areas of inflammation, that is skip lesions, are characteristic of Crohn's. While in ulcerative colitis, there are continuous areas of inflammation. There is a normal mucosa, then there is a inflamed mucosa seen in Crohn's disease. So patchy areas of inflammation if you see through endoscope, while colonoscope. But in ulcerative colitis, there are continuous areas of inflammation. Then Crohn's disease, the ulcers are serpiginous, snake-like ulcers, and deep. While in ulcerative colitis, the ulcers are continuous ulcers. Snake-like ulcers, serpiginous ulcers are seen in Crohn's, while continuous ulcers are seen in ulcerative colitis. Then depth of inflammation. Usually, as we had seen earlier in the picture, the Crohn's disease involved all the parts. Muscle layer, mucosa, there is a fat stranding, okay, on the outer serosal layer. So there is a transmural involvement. While in ulcerative colitis, it is only mucosal, shallow involvement, okay. Then fistulae, stenosis, more common in Crohn's, less common in ulcerative colitis. Then autoimmune disease, more commonly associated with Crohn's. Then cytokine response, usually Crohn's disease is associated with Th17, while ulcerative colitis is associated with Th2. Why it is important? Deciding for the immunosuppression. Then we have granulomas on biopsy. May have non-necrotizing, non-periintestinal crypt granulomas, while in ulcerative colitis, non-periintestinal crypt granulomas are not seen. So, crypt abscesses or granulomas are more common in CD. Surgical care often returns following the removal of the affected part. Surgical cure. Usually, it is a relapsing condition. Crohn's जो होता है, it is a relapsing. While ulcerative colitis, once the inflamed part of the colon is removed, it is curable. Okay. Then smoking. Crohn's disease has a higher risk for smoker, while ulcerative colitis has a low risk for smokers. So you need to remember this table. These differences are important. Clear? Now, how you treat these patients? Basically, it is an inflammatory disease, so you cannot completely cure it. You have to improve the quality of the life of the patient, terminate the acute attacks and induce the clinical remissions, prevent the symptoms during chronic symptomatic periods, prevent or reduce the rates of complications, use the most cost-effective drug treatment. Okay, avoid surgery is possible, and replacement of the nutrients that such as vitamins A, D, E, K if necessary in cases of malabsorption. So IBD, Crohn's disease, was an important DD in malabsorption also. Now, non-pharmacological treatment: avoid smoking, reduce alcohol consumption, avoid the use of NSAIDs, avoid spicy, fried or oily food, take fiber-rich diet tolerated that includes tender cooked vegetables, canned or cooked food, starches, uh, mm, like cooked cereals and whole wheat noodles or tortillas. As you can see, the dietary pattern is basically Northern European. Okay. To incorporate more omega-3 fatty acids in the diet, these fats may have anti-inflammatory effects and they are found probably in the fish. Now, how do you treat? Mild, moderate, severe. In mild cases, you only need to treat it with antibiotics and aminosalicylates, sulfasalazines. Then in moderate, you need to use immunosuppression with steroids and immunomodulators such as 6-markaptopurine, azathioprine or methotrexate. Then we have biologicals if the patient is not responding, and then ultimately in severe diseases, surgery. Okay. So in mild cases, only aminosalicylates and antibiotics are sufficient. Okay, if the patient is in moderate category, then only you will need to give a immunosuppression. Pharmacological treatment: the major types of drug therapies that are used in IBD include aminosalicylates, corticosteroids, immunosuppressive agents, TNF inhibitors, then antimicrobials. aminosalicylates. These agents have anti-inflammatory effects and they are used to maintain remission and to induce remission of mild flares of the disease. Examples: sulfasalazine and mesalamine. These are still most commonly used drugs to treat milder forms of IBD. Sulfasalazine and mesalamine are used to treat mild to moderate disease to maintain remission induced by corticosteroids. So you can use it in mild to moderate diseases and also in the patients in which the remission has been induced by corticosteroids. In the maintenance therapy, you can use aminosalicylates. Sulfasalazine is used for ileocolonic and colonic diseases. The side effects are hemolytic anemia and pruritic dermatitis. So you need to keep a watch on the counts of the patient. Pentasa is a recently developed self-sustained preparation coated with ethyl cellulose that delivers 5-ASA to the distal ileum and colon. They are available in the form of suppositories. You can give them to the patients and they can use it for long term. Then we have corticosteroid. What is the dose? The dose is 1 milligram per kg per day, which are effective in decreasing the disease activity and inducing the remission in most of the patients. However, due to undesirable side effects, long-term use of corticosteroids is not recommended. So they should be used only in the active phase of the disease. Once patient is remittent, you need to shift to aminosalicylates. Oral or parenteral corticosteroids are indicated for the treatment of ambulatory patients with moderate to severe colitis whose symptoms cannot be controlled by aminosalicylates. So if the patient's symptoms are not able to be controlled by aminosalicylates or ASAs, then you can use steroids. We all know the adverse effects of steroids. Then we have immunosuppressive agents. If it is impossible to taper corticosteroids or frequent relapses occurs, then only immunomodulating therapy should be considered. However, the use of immunomodulators is not approved by the National Health Insurance Scheme in USA. So azathioprine and 6-marcaptopurine are used due to their steroid sparing or steroid reducing effects, since approximately 50% of patients experience the adverse effects from corticosteroids. Due to delayed onset of actions, these agents are not used to treat acute cases. Only where the patient has failed on steroids, then only you can start these drugs. Okay. Cyclosporine and tacrolimus have been used to treat the acute steroid refractory UC when the surgery seems inevitable. Then we have TNF alpha inhibitors. Increased production of inflammatory cytokines, especially tumor necrosis factor alpha, has been described in both normal and inflamed mucosa, as we had seen in the pathophysiology. These agents prevent the endogenous cytokine from binding to the cell surface receptors and exerting the biological activities. These agents adversely affect the normal immune response. Thalidomide was initially used, but now it has been abandoned. Then we have infliximab, which is a humanized monoclonal antibodies. It bind to the membrane bound TNF and thus prevents the cytokine from binding to the cell surface receptors. So these are multiple immunological therapies available. Infliximab. Okay, then we have golimumab, then we have adalimumab. In the recent years, the use of these therapies in IBDs has increased. But still, in our old patients, we have seen that they maintain very well with aminosalicylates. Okay. So first start with aminosalicylates. Then you can use steroids, but since the steroids were having so many side effects, so recent literatures have been advocating the use of biologicals for the treatment of these patients, but still we like to prefer to treat our patients in the same way, that is aminosalicylates followed by steroids and followed by biologicals. Okay. Then antimicrobial agents which can be used are metronidazole and ciprofloxacin, which can be very useful in treatment of mild to moderate disease, particularly in patients with perianal and infectious complications. Sensory neuropathy, which may be seen with the long-term use of metronidazole, usually resolves completely or improves after the discontinuation of the drug. So need not worry if the patient develops neuropathy. Once you will discontinue metronidazole, it will go off. Now, what are the surgical options available for IBDs? Proctocolectomy, what with ileostomy. Now, what is proctocolectomy? You remove the colon and rectum. If UC is severe, surgery may be required to remove the entire colon and rectum and bring a part of ileum, that is the end of the small intestine, through a small stomal opening in the abdominal wall to allow the drainage of intestinal waste out of the body. The second part of the procedure is called ileostomy. After the procedure, the external bag must be worn over the opening to collect the waste. It can be a very uncomfortable situation for the patient. Okay, it can be if the patient has to wear a ileostomy bag for a long period of time, it can be an uncomfortable situation for anyone. Then restorative proctocolectomy, also known as ileoanal pouch anastomosis, involves removing the colon and the rectum, but the patient can continue to pass stools through the anus in place of an ileostomy. The ileum is fashioned into the form of pouch and pulled down and connected to the anus. So earlier they used to do proctocolectomy with ileostomy, then they moved to restorative proctocolectomy. Then for Crohn's disease, as we all know, strictures are very common in Crohn's disease. So stricturoplasty. What do we do in stricturoplasty? If an area of bowel narrows, this widens the area without removing the portion of the intestine. That is, you give an incision, open the stricture, and then take the part of the bowel and reseal it. Okay, this will be more dealt with you in your surgical classes. Okay, then resection, you remove the part of the stricture and then seal the bowel. Okay, so what is inflammatory bowel disease? It is an inflammatory condition affecting the GI tract. It can affect portion of the GI tract, or it can affect a whole of the GI tract, as in cases of Crohn's disease. Okay, it is a disease of Caucasians, especially Ashkenazi Jews. Okay, then what are the agents? Still there is a debate about the exact etiology, but there are multiple factors which has been said to be involved in these. There can be infectious agents, which can be viruses and bacteria. Atypical mycobacteria are more commonly involved. Then there can be dietary factors, and there can be genetic factors, environmental factors, which can be responsible. So Crohn's disease, as you can see, involves the whole of the intestine, while in UC you can see only the mucosal portion of the intestine is involved. Okay, then what is the pathophysiology? Antigen enters through the epithelial cell defect and activates the immune system. What does it activate? It activates the dendritic cells. Then which cells? B cells, macrophages, T cells, leads to the release of various interleukins, TNF, alphas, then ultimately which causes the inflammation of the mucosa. Okay. Clinical manifestations, there are some common clinical manifestations which are seen both in cases of Crohn's and I'll say one thing about the clinical manifestations, GI bleed is less commonly seen or rarely seen in Crohn's disease, while GI bleed is more common a feature of ulcerative colitis. Okay, hematochezia is more commonly seen in ulcerative colitis. So diarrhea, abdominal pain, which is cramping and bloating, hematochezia, low fever, decreased appetite, weight loss, anorexia, fatigue, arthritis, all these can be a common features. Then there are certain features which are during the active phase of IBD, that is conjunctivitis, iritis, episcleritis, mouth ulcers, fatty liver, liver abscesses, mesenteric vein or portal vein thrombosis. Venous thrombosis is more common during the inflammatory or active phase of the disease, while some features are unrelated, that is autoimmune hepatitis, primary sclerosing cholangitis, cholangiocarcinoma, gallstones, amyloidosis, sacroiliitis, metabolic bone disease. Now the diagnosis can be established by physical examination, endoscopic biopsies and blood tests. So what are the physical examination findings? Look for oral ulcers, look for abdominal tenderness and any masses in the abdomen, anal tags, fissure, features of nutritional deficiencies and features of growth retardation, especially in children. Now endoscopic biopsies helps us to differentiate between the Crohn's and the ulcerative colitis depending upon the area of involvement. Ileocolic regions are more commonly involved in the Crohn's disease, while rectum and whole of the colon is more commonly involved in the ulcerative colitis annexus bed. Then you can do a rectal biopsy, get a histological confirmation. Then these are absolute. Then we have blood tests, which includes tests for anemia, hypoalbuminemia, CRP levels. All these can be done. Then there are certain antibodies such as ASCA, which are positive in Crohn's, while ANCA, which is positive in ulcerative colitis. Then you need to know the differences between the two. Now, basically, Crohn's disease, we all know that terminal ileum is more commonly involved, while ulcerative colitis, it is the rectum and the colon which is more commonly involved. Transmural inflammation is more common in Crohn's, while it is the mucosal portion which is more commonly involved in the ulcerative colitis. Then in Crohn's disease, there are patchy areas of distribution of inflammation, while in ulcerative colitis, it is a continuous involvement. Then in endoscopy, you can get, if the patient doesn't respond to steroids, move to immunosuppressants such as azathioprine, methotrexate. But problem with these immunosuppressants is that it does not act in the active phase of the colitis. So you need to give a cover of steroid. Okay, then move to it. Then we have the newer drug therapies such as biologicals, which are being increasingly used and are being now commonly used for the treatment of these patients. And if the patient fails on all these things, then ultimately surgery can be performed. So this is all about IBD that you should know. Now, which of the following is characteristic of Crohn's disease but not of ulcerative colitis? Gross rectal bleeding is consistently observed. Inflammation is limited to the mucosa except in severe cases. Inflammation is widespread and consistent, and the rectum is frequently unaffected. Answer is rectum is typically spared in Crohn's disease, whereas in ulcerative colitis, the rectum is usually affected. IBD is more prevalent among the individuals of which of the following ethnic background? Northern Europeans. Okay. It is more prevalent in Northern European and Anglo-Saxon descents, and it occurs 2 to 4 times more frequently among the Ashkenazi Jews as compared to non-Jewish whites in the same region. Okay. Which of the following conditions strongly linked to IBD and can occur regardless whether the patient is having a IBD flare-up? Episcleritis, aphthous stomatitis, erythema, and uveitis. Uveitis. 35-year-old woman presents with chronic crampy abdominal pain, intermittent constipation and diarrhea, but no weight loss or GI bleed. Her abdominal pain is typically relieved after bowel movements. Colonoscopy, upper and GI endoscopy with biopsy shows normal results. Stool cultures are negative. What is most likely diagnosis? No, it is Crohn's. Crampy abdominal pain, intermittent constipation and diarrhea, but no weight loss or GI bleeding, more suggestive of Crohn's. Intermittent constipation and diarrhea. That is the key. Intermittent constipation and diarrhea usually not seen in IBS. If a patient comes to you in the OPD and he is giving a history of intermittent constipation and diarrhea, always think that some organic pathology is present. It could be a IBD, it could be a tuberculosis in India. Alternating episodes of constipation and diarrhea should always raise an alarm. 25-year-old man with ulcerative colitis is hospitalized and has developed abdominal distension, fever, and a 7 centimeter transverse colonic dilatation on X-ray. Which is the next best step? Infliximab, steroids, antibiotics, and prompt surgical consultation. ASA. He has ulcerative colitis. He is having abdominal distension, fever, and you can see a dilatation of transverse colon of 7 centimeter. What will you do? Whether you will call a gastroenterologist or you will call a gastrosurgeon. It is a toxic megacolon. It can perforate and patient can die. So, surgery. And risk of perforation, you need to get it operated. So, this is all about the IBD that you need to know. Roll number 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12, 11, 11, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30, 31, 32, 33, 34, 35, 36, 37, 38, 39, 40, 41, 42, 43, 44, 45, 46, 47, 48, 49, 50, 51, 52, 53, 54, 55, 56, 57, 58, 59, 60, 61, 62, 62, 63, 64, 65, 66, 67, 68, 69, 70, 71, 72, 73, 74, 75, 76, 77, 78, 79, 80, 81, 82, 83, 84, 85, 86, 87, 88, 89, 90, 91, 92, 93, 94, 95, 96, 97, 98, 99, 100, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 2021 batch, 20 roll number, 30, 95,